So our next presenter, we're very lucky to have Dr Matthieu Grégoire, who's a visiting academic. He's a clinical pharmacologist specialising in the therapeutic drug monitoring of anti-infective agents. He's an associate professor at Nantes University Hospital in France. For 2024, he is a visiting academic with the Antimicrobial Optimization Group here at UQCCR. His current research focuses on optimizing anti-infective therapies through population modelling, including model-informed precision dosing, with a recent interest in long-acting antibiotics, which is shared by most of the world, I think. Matthieu is actively involved in several societies and is a member of the steering committee for the TDM research group of the French Society of Clinical Pharmacology and Therapeutics. So thank you very much for coming today to talk to us about precision dosing of everyone's new favourite drug, which is dalbavancin.
So thank you, Amy, for this kind introduction, and thank you for the invitation to talk about this special antibiotic. So here is my disclosure about this topic. And let's go. Why is dalbavancin so special? First, probably not for the antimicrobial profile, because it's more like a classic glycopeptide, like vancomycin, like teicoplanin, because target is exclusively gram-positive bacteria. Of course, Staphylococcus, and we will focus mainly on Staphylococcus today because PKPD target is very low for Streptococcus, so probably TDM is not relevant for Streptococcus species, even for Streptococcus pneumoniae. And we have very few data about Enterococcus and Corynebacterium, so we will focus on Staphylococcus. Dalbavancin is special mainly for the extensive half-life, at least 2 weeks in normal renal function patients. And as we can see, even 6-8 weeks after the last infusion, we have a detectable concentration in plasma. So that allows very spaced administration, and that's why dalbavancin is, I think, very, very special. And that's why it's used in a wide range of indication. The in-label indication is a skin and soft tissue infection, but it's not the main use of dalbavancin. As you can see in this small cohort of patient, of French patient, it's less than 20% of the patient. And in fact, it's mainly used in off-label indication, mainly BGIs, even prosthetic joint infection, and as well endocarditis, of course, and to a lesser extent in vascular infection, vascular graft infection, catheter, bloodstream infection, and so on. So dosing regimen is just clearly defined for label indication for skin and soft tissue infection, where we need just to cover 2 weeks. So it's very easy to cover 2 weeks with one dose of 1500 milligrams. We know based on recent studies that 2 doses of 1500 milligrams spaced by 1 or 2 weeks, that we can cover 5-6 weeks of treatment. But the big question is when we need more than 2 doses, more than 6 weeks for the treatment, where probably TDM will be very helpful. So what can we learn from murine models? Because we have no human PK/PD model, unfortunately. So we have 2 murine models in literature from the same team based on neutropenic mice, thick infection model. And what we can see is that free AUC 24 hours on MIC is probably the best PK/PD index with a nice correlation with efficacy. Peak concentration is well correlated as well, but the time spent above the MIC is not probably not a good index for dalbavancin. So after that, we have probably to choose the antibacterial objectives. Depending on the type, the severity, the expected burden of the infection. That's why probably in non-severe infections such as skin and soft tissue infections, such as in suppressive long-term therapies, we will only need a stasis endpoint with probably a very low exposure, but for long-term in suppressive therapies. But in severe infection, we will probably go for at least a 1 log kill endpoint, and maybe even if it's not really proven, in very severe infection, in deep-seated infection, when inoculum is high, especially when prostate is in place, we could discuss the 2 log kill endpoint. And the last thing we learned from the murine model is that probably models support widely spaced regimen, but with very high dose. So when we use high dose but very spaced, it's better than low dose, very close finally, as we can see on this graph. So high dose, what are high doses? Finally, our doses are only doses based on the 1500 milligrams regimen. So based on this data, how could TDM be conducted? So we are in a paradigm change, a paradigm shift, because it's very easy to transpose a PK/PD target based on IUC 24 hours when we have daily antibiotics such as daptomycin, for example, because at day 1 AUC finally will be very similar to the day 2, and it will be very easy to adapt. For dalbavancin, it's very different because on day 1, on day 2 it will be different, and of course on day 14, 2 weeks after the infusion, it will be again different. And finally, I think that antibacterial objective would be probably different because on day 1 we probably wish a very high bactericidal effect, and that will not probably the case on day 14 and maybe after. So we can discuss to combine probably 2 targets. A target, the first target will be based on murine model, so the mean AUC 24 hours during the whole interval between 2 administration, that probably will target endpoint of 1 or 2 log kill, and maybe during the last days of the interval, probably we will target mainly a stasis endpoint. So I think that could be fair to combine both targets. So we also need to take into account additional parameters, and we need some new data probably for these parameters. First, the protein binding, because dalbavancin is highly bound to protein. Product information displays a value for the protein binding of 93, but a recent study said that it was around 99%. It's very different when we rely on free concentration for the PK/PD target. So I think we need more data, more robust data, and maybe TDM should rely on free concentration, on direct free concentration determination. So in the future, it will be probably the case. Bacterial susceptibility, very important because we have a high variability in MICs, intraspecies for Staph aureus, for example, but also between species because Staph epidermidis will display lower MIC, Hemolyticus will display probably higher MICs. That's what we observe in practice. So be careful with Hemolyticus specifically, and I think it could be relevant to determine actual MIC by broth microdilation or also by e-test. It ran well. It ran very well. There's some publication on the topic. So because we have a PK/PD target based on MIC, we probably need an actual MIC. And the last point is the tissue diffusion, because the label is for skin tissue, skin and soft tissue, where dalbavancin diffuse pretty well, very well, we can say. It's close to 100% of diffusion compared with plasma 2 weeks after the last infusion. But for bone, it's lower. And in fact, we have no information in valves, in vegetation for endocarditis. So we need to be to manage very carefully this patient and probably targeting high endpoint and maybe too low kill endpoint in this patient, very severe for endocarditis. So dalbavancin TDM only in staphylococcal infection, I think. Only probably for long-term duration exceeding 6 weeks, based on the free IUC 24 hours. But as you can see, maybe I think 2 targets of IUC with 2 different endpoints. I didn't talk about toxicity threshold just because we have no threshold for that, and also because dalbavancin is pretty well tolerated. We have no renal problem. It's well tolerated. Actual MIC should be recruited, and as I said, probably new data are needed for protein binding because I think it's a major issue now, so we need new data. Thank you.
That was wonderful. Thank you. I don't think we have any questions on the chat. Anyone got any questions in the room? No, that was wonderful. I think there's a lot of repeating themes tonight, which is think about your PK/PD target, think about how to give the drug, and then think about your efficacy and toxicity. The point of the MIC comes up a lot, doesn't it? When you're thinking about efficacy targets, the MIC is often integrated into those. But then your toxicity targets, I was going to bring this up. In the previous presentation, Dr. Julie calls them plain MICs. She talks a lot about plain MICs because once you remove the MIC, you have an actual number. When you've got the MIC, you've got a ratio. But you've got to think of both because one's for efficacy and one's for toxicity. Anyway, it's very similar how precision dosing seems to work through all our experts. Start with the target, pick your dose, and then think about the bug and the toxicity.